promising treatment in hormone receptor positive metastatic breast cancer. We prepared the this is disclaimer. So welcome to so housekeeping. Just we have the Q&A, the polling question, QR code. Scan the QR code and complete the evaluation form. So this is the main lecture. Then we'll have another Q&A and another polling question. So here is the polling question. 60-year-old woman, hormone receptor positive, HER2 negative breast cancer, so received the surgery, the adjuvant and endocrine therapy, AI 4 years. Then developed metastasis in the bone and pleura, but she has no minimal symptoms. In this setting, first-line setting, which of the following molecular biomarker is most important to inform first-line treatment decision? Please scan the QR code and the ESR1 mutation, because hormone receptor positive, BRCA mutation, hormone receptor positive also associated with BRCA mutation. A PIK3CA mutation was 30 or 40% percentage are related to PIK3CA mutation, all of the above. No music? Okay. Most of the audience are voting for the all of the above. So today's speaker is Professor Sherko Kummel, so well known in Breast Cancer Society. Actually, he's the clinical director of the chairman of the Interdisciplinary Breast Cancer Unit, clinical Essen MIT in Germany. Also, he's very active in breast cancer research program. So I'd like to invite Dr. Kummel.
So, dear colleagues, many thanks for the invitation. And the answer was to do everything. So no more resources, no questions. We do everything and then everything is clear. As usual, what I'm telling my students and others about biomarker measurements, first of all, if I have a decision afterwards, I do something. If I have no decision, it's research. Because otherwise I have to tell the patient something, and the patients are afraid about that, what that means. So I think we have to negotiate where we are in these situations. These are my disclosures. First of all, as we all know, I think this is, the largest populations what we have in our MDTs. Over 70% are HR-positive disease. And eventually, up to 1/3 of our patients have a relapse over the time, and we know with late relapses together over 10 years. And as we always talking about that we have a median PFS at the CDK4/6 inhibition in the first-line situations of maybe 2 years, that means 50% will relapse in the first 2 years and not after the 2 years. And I think we have to treat them probably maybe in the better fashion with our patients. And what we have learned is, after the huge success of the median PFS of 2 years of CDK4/6 inhibition of an overall population in these situations, if we come to the second line after CDK4/6 inhibition, I think we're dealing around 5 to 6 months in combination therapies and where we go in the future. So now let's do a journey, what we're doing in our daily routine and what's coming in a normal week for you. On Monday, there's highly sensitive patients at your ambulance, de novo metastatic or very long distance disease-free interval for more than 15 years after completion of endocrine therapy, only bone metastasis, and it's asymptomatic. On Tuesday, there's another patient is coming to your ambulance and likely sensitive in the situations, long distance disease-free survival, interval 2 years after completion of adjuvant therapy, probably at the year 7 or 8 after 5 years of endocrine therapy, but predominant bone and soft tissue metastasis and minimal symptoms. You go back your ambulance on Wednesday, and then you see a patient's moderately sensitive, a short or shorter interval, disease-free interval, and it's 6 months after completion of adjuvant endocrine therapy, bone and visceral disease, a few symptoms. And of course, on Thursday, you're coming back and said, maybe what is the surprising, what patients are coming, and you see patients with moderately resistant situations. All these patients are HR-positive disease, metastatic patients. Progression on endocrine therapy, maybe 3.5 years after initial diagnosis with more extensive visceral disease. And then you say, what happens on Friday? And as usually on Friday comes the most aggressive situation, mostly at 2 p.m. or 3 p.m. if you're thinking about the weekend, and this is maybe in Germany, thinking at 2 p.m. on the weekend. Likely resistant, early relapse, under endocrine therapy, fast progression, life-threatening aggressive disease, and an extensive visceral crisis, probably. And all these patients is the range of our patients that we see in the ambulance with HR-positive metastatic disease. And maybe we are thinking, and sometimes not thinking about, to differentiate where we are and what to treat with our patients, only to looking at time frames because of endocrine sensitivity. If you're looking more closer to principles of endocrine resistance and therapeutic strategies, I think, unfortunately, sometimes we can do everything, but it's not working, despite whatever we are doing in those situations. And then, as we learned in these situations, if we have probably an estrogen-independent pathway, this is typical, the development-acquired mutations of ESR1 mutation, and of course, this is the playground for the SERDs in the situations to treat the patients well. And then we have some other patients are coming probably with alternative signaling, probably CDK4/6 is a combination therapy, PI3 kinase, AKT, mTOR pathway, as you know, and probably this is a backbone for combination therapies, how to tackle the endocrine resistance with our patients. So what we have to think about if the patients, like if you look back last week with our different patients that you saw, you have some patients with an ER loss because you do a rebiopsy for these patients, and conversions lead to resistance to the estrogen deprivations or ER inhibition. Some patients develop under the pressure of aromatase inhibitors as longer as the exposure is, get ESR1 mutations, and you have an estrogen-independent activity in this situation. And sometimes you have an alternative signaling. This is mostly the PI3 kinase, AKT, mTOR pathway in these situations. And this is all about 50% of our patients. Looking to clinical factors coming together with molecular factors. First of all, the primary and endocrine resistant situations. Adjuvant primary resistant is the relapse during the first 2 years under endocrine therapy. Metastatic is the progression during the first 6 months as a primary endocrine resistant. Secondary endocrine resistance under endocrine therapy or less than 12 months after the end of the endocrine therapy in the adjuvant situation, or more than 6 months in the first or second line in the metastatic situation. And of course, there are a lot of cofactors coming implemented, as I showed you, your normal week, what you have in your ambulance, the age, patient preference, performance status, and comorbidities. Looking at the molecular factors where we are and what we are doing a deep dive today is, I think we have the intrinsic resistant mechanism, PI3 kinase, AKT, PTEN pathways, the germline BRCA mutations, some somatic too, TP53, and we have the acquired resistant, mostly known as the ESR1 mutation. How frequent these mutations are is the big question. If the patients are coming in our ambulance, is the PI3 kinase mutations is 35 to 40% of our patients, and as an intrinsic mutation, we can measure it on archived tissue. This is an important thing. If we want to measure something, we only have the questions, do I have a decision afterwards? And then I have the question, what I have to measure, maybe liquid or tissue, the second question, and the third is when to measure in this situation. This is important. PI3 kinase as in intrinsic mutations, we can find this as in the archived tissue, maybe from a primary tumor. If we look for that one and summarize the overall data, what that happens, the median overall survival is shorter if the patients have PI3 kinase mutations. Overall survival is nearly 9 months, 8.4 months shorter in this population. So we need, this is an unmet need to do something. And as we know, we have an action mutations as the PI3 kinase AKT pathway. Looking to the ESR1 mutations, is something is acquired, maybe the pressure of resistance and refractory disease because of aromatase inhibitors. You see in different lines of endocrine therapy, as longer do you have that, as higher is the exposure and as higher is the development of ESR1 mutation. In the second, third line, more than 40% of our patients. Is this something with worse prognosis? Yes, if you summarize and looking at the data, patients with ESR1 mutations have a worse prognosis versus not, versus wild-type patients, and are predominantly more visceral disease, mostly liver metastasis in these situations. And as we come back, how to treat our patients if we measure something, I think always to think about, and this is one paradigm in this change, we have to treat biology. We never treat by a localization. To say probably visceral disease is something for chemotherapy or ADCs, and maybe bone mets probably is something more for targeted therapies like ESR1 mutation with less comorbidities in the situations. And of course, we have the actionable predictive treatment with ESR1 mutations with the approval of these SERDs. If you combine this, and you decided, most of the audience decided, I have everything, I'm free of charge to pay for everything, I measure everything. So first, my questions would be, does it make sense if you do ESR1 mutations, you get the signal ESR1 mutations, what do you do? And this, do you change something in your algorithm? If you have PI3 kinase at that situations for the patients and ESR1 mutation, what you are giving? Probably you're giving inavolisib and palbociclib. Do you change something to fulvestrant plus versus SERD? Mostly not in the situations. This is my recommendations for that one. Always I'm thinking to have a decision because of a measurement I'm doing on that one. If you follow up this, and this is interesting, in the metastatic situations, we found more and more biomarkers and targeted therapies, SERDs, PI3 kinase, maybe in triple-negative PD-L1. And then we come to the early breast cancer situations, everything is not true. So this is another point we have to talk maybe later in the situations. The evolving treatment landscape in HR-positive disease, increasingly more extensive the biomarker testing in these situations. PI3 kinase mutations with the recent approved situations, the INAVO120 trial with inavolisib, palbociclib, and fulvestrant as approval as a primary endocrine resistant patient populations, capivasertib and fulvestrant mostly in a second-line situations, and the under trial maybe if you have more sensitive population, the INAVO123 trial is maybe under randomization in this time, of course, with inavolisib, palbociclib, and letrozole, and you have the next one, the gedatolisib, as an IV formulation plus fulvestrant and CDK4/6. This is maybe trials are ongoing. Looking at the ESR1 mutations, mostly second-line, the EMERALD data with elacestrant monotherapy, imlunestrant, now approved by the FDA after the EMBER-3 data for ESR mutated patients. We have the SERENA-6 data, longitudinal maybe measurement of ESR1 mutation during the first-line situation, switching to camizestrant as the third oral SERD. And we have the data of combinations in the second line, like giredestrant as a SERD and everolimus in the situations, we're coming later back to that. And the PIONEER trial in the combination with CDK4/6 inhibitor, this trial is under randomizations and is ongoing in this. BRCA, there's only a small trial is running on PARP inhibition together with SERDs. And then, of course, for metastatic disease patients, we have the SERDs additionally too, with HER2 overexpression for PI3 kinase populations and HER2 overexpression with inavolisib, the INAVO122 trial, and HERAD-ERA trial for the patients, starting with an taxanes dual blockade, and in the maintenance phase, switching to insert plus dual blockade. As we all know, this is one of the most challenging questions today in the Oxford debate, maintenance after something. What is the best strategy in the first-line situations? We get more and more maintenance data. So that's why the HERAD-ERA trial would be important to in HER2 overexpression if the SERDs, given additional advantage for our patients. Now it's coming to the tailored combination therapy in the first-line treatment, what we're talking about. As you all know, if you're looking at the guidelines, we have maybe in the sensitive populations, this is where the patients probably on Monday and Tuesday, mostly probably on Wednesday too, if the patients come to your ambulance, CDK4/6 plus aromatase inhibitors. If you're coming more and more to the Thursday, sometimes Wednesday, Friday population, as I showed you, is CDK4/6 and fulvestrant. And at that time, you have to measure PI3 kinase. That is the minimum what you have to do in this situation. I think we can answer later if you do it in tissue, if you do it in liquids, etc., the situations, but you have to do it because you have an approved situations in inavolisib, palbociclib, and fulvestrant. This is biomarker selected. Coming back to our CDK4/6 established in the first-line situations, you see the primary endpoint, the median PFS, is similar for all these. If you're looking at a hazard ratio of 0.6 and 0.5 around that one. And if you combine everything, including real-world data, you see that all CDK4/6 inhibitors have an overall survival advantage. On the trial level only, this was proven by the ribociclib and abemaciclib in the situations. And now it's coming to the next one. If the patient, and this is important when you measure what in the situations, PI3 kinase mutation patients with poor prognostic features. Who are the patients? Patients with an endocrine resistance. All patients under endocrine adjuvant therapy or maybe less than 12 months after end of the endocrine therapy. This is the huge, completely populations. In my example, this was from Wednesday to Friday as the patients. You have to think about the combinations of inavolisib plus palbociclib and fulvestrant if you have a positive PI3 kinase mutation for these patients. So at the end, you have to measure it. This trial was randomized only for 300 patients, but highly selected because biomarker-driven with PI3 kinase mutations, triplet, inavolisib, palbociclib, and fulvestrant versus placebo-controlled in the situations. Looking at the data, and if you do it biomarker-driven in the situations, you see in the resistant population a huge benefit with a hazard ratio of 0.43, an advantage for using inavolisib as a PI3 kinase inhibitor plus palbociclib and fulvestrant in the situation. The consistent PFS was about all the subgroups, and of course the safety, as we know, was consistent with the known profiles that we know in these situations. Again, we saw an overall survival advantage with a hazard ratio of 0.67, and this was, again, the overall survival advantage for this population was consistent across all the key subgroups. And because of this, maybe groundbreaking trial, it's changing our practice guidelines and coming to the guidelines, like in the ESMO guidelines, you have to measure for this population PI3 kinase, and if you measure it, the standard of care would be the combination with inavolisib. Now we come to the measurement, and you see in different guidelines, major treatment guidelines recognize the importance of PI3 kinase mutation testing in patients with HR-positive disease in this situation. Now we're going in the next step and talking about combinations and et cetera or not. Always, if you're doing PI3 kinase, AKT, and mTOR pathway situations, is always a combination therapy, starting with Capitello. And once again, I think we have to look at it after CDK4/6 inhibition. If you have an AKT P10 mutation, the response, the median PFS of capivasertib is 5.5 months. We have to keep in mind. So maybe, as always, 7 months is for the ITT population. The FINA trial is a trial with ipatasertib as an AKT-specific inhibitor, and the Victoria trial with gedatolisib, an IV compound in the situation. And you see the Inavo 120 trial with inavolisib in these situations. And this is a pure first-line trial, and this is important. You measure it if you have the first diagnosis for patients with metastatic HR-positive disease. So coming to the second line, this is questions, because unfortunately all our patients coming to the second line, then we have to separate it now to non-biomarker selected situations. First of all, maybe if it didn't start in the first line, then you have to take the CDK4/6 inhibitors. Fulvestrant, probably with all the new compounds that you have, probably not the best choice as a monotherapy, as we all know, is not more than 2 to 3 months. Then it comes to the combinations, I think often used. We have the exemestane and everolimus combinations from the Bolero trial, and from the MANTA trial, the data from fulvestrant and everolimus, and a lot of colleagues using this combination for patients without any mutations in the second-line situations. If you go focusing on biomarker-selected situations in the second line, then we have alpelisib, PI3 kinase inhibition from the SOLAR trial, capivasertib from Capitello, or if you have in ESR1 mutations, the monotherapy with elacestrant and imlunestrant as the approved compounds in these situations. Let's looking at the data for that. If you look at the data, the median PFS in these situations, and this is really important because normally we don't have this one in the second line, that there's no prior CDK4/6 inhibition. Normally all the patients have prior CDK4/6, and if you see that one, these are the PFS, median PFS situations in months and the second line situations. So this is the unmet need today for me to say how we can hire it and bring it more to 6 months in this situation. I think as a threshold where we have to go after CDK4/6 inhibition in the second line situation. Ongoing phase 3 trials where we are going, and that's why it's rapidly changing. Maybe our algorithm, I think every 3 to 6 months we have to change something. I think we saw giredestrant, everolimus, the Evera data, we saw the EMBER-3 data as a combination independently effective of SERD and CDK4/6 inhibitor or SERD and mTOR inhibitor like everolimus. You see in the biomarker-driven situations, the wild type for the triplet for gedatolisib, the FINA trial with AKT inhibitor, alpelisib, etc. Now we have the EPIC-B5 trials versus fulvestrant with a benefit in these situations. And the NAVO 121 trial is under investigations, and we saw the first PROTECT data with giredestrant for ESR1 mutations. So this is something which is ongoing or last releases, but not approved in this situation where we have to think about it. And probably what is coming and have a wider range of algorithm and treatment choices, what we can go with our patients. If you're looking at the phase 3 trials of SERDs monotherapy in combination versus standard of care in ESR1 mutations, you see, if you look at the EMERALD data and the overall populations, you see this difference versus fulvestrant. With giredestrant, you see the difference. It's a bit 5 months to that situation, but you can't compare. You can't say PROTECT is more effective than SERD. Why? EMERALD was the first-in-class trial. There are a lot of patients, 20% of the patients had the chemotherapy before. A lot of patients are on the third line. So it's a different populations we have to think about this. And then we saw the combination therapy. First, the EMBER-3 trial, imlunestrant in combination with abemaciclib, and for ESR1 type and ES mutated patients as a combinations. And this trial led to the approval of imlunestrant monotherapy for second-line treatment. And we saw the Evera data, everolimus in combination with giredestrant in the situations. And you see the newer trials has 100% of the patients with CDK4/6 prior, maybe in treatment algorithm. So we have this data. And now we jump over the 6 months, probably with the combinations in the select patients group. And you see the ITT population. Maybe the question is if all patients will benefit only for ESR1 mutations, or is it maybe the ITT population? As a clinician, my standpoint is I want maybe as wide as possible the approval, then I can maybe choose my patients for that one. I don't know what in the future is coming by the agency. Looking at the data for that one, we see that the Evera trial was in hazard ratio 0.38 for ESR1 mutated situations. Giredestrant plus everolimus. And this was a trial not versus monotherapy like fulvestrant as probably as a standard of care. This was a trial versus combination therapy, exemestane or fulvestrant plus everolimus. Despite this combination versus combination, you see this huge advantage from doubling the median PFS. And this you see in the ITT population too. The overall response and the duration of response benefit was irrespective of ESR1 mutation status. It was well tolerated, as we know. The SERDs are well tolerated. We have no additional safety signals from this combination. And this is what you see, the overall survivor analysis in both the ITT and ESR1 mutations were major, but you see, once again, the first probably hint with longer follow-up and this hazard ratio of 0.7 for overall survival in 100% CDK4/6 pretreatment patients. I think this is the next probably standard of care for for our patients. If it's for all comers like DT, or is it for ESR1 mutations, I think we have to look what the agencies are doing with that one. Looking at the biomarker, non-biomarker selected options as we're measuring something, you see in the first line, this is what you have to do, endocrine therapy and CDK4/6 inhibition. Maybe sometimes you have to think about of measurements as a liquid biopsy, ESR1 mutation like serina-6. You have to think about in resistant populations at that time about inavolisib after measurements of PI3 kinase mutation plus fulvestrant and palbociclib. Going in the maybe second-line situations, fulvestrant, everolimus, or maybe imlunestrant, abema as the readout but not approved, elacestrant, imlunestrant, vepdegestrant, you see if this is approved, and capivasertib, alpelisib, PI3 kinase inhibitor, or gedatolisib of weekly IV. Maybe we have to see what's coming in the situations. And this is the journey what we have maybe to keep in mind and we have to do with our patients. This is something what I measured, and this was really well balanced and educated us at the ESMO discussion by Alessandro Gennari to see probably, I think in the second line, we have to select the patients to jump over the 6 months. This is an unmet need, what we have to go with our strategy in the situation. So the take-home message for today is the targeting multiple pathways simultaneously to novel tailored combination therapies may address the high unmet need in patients with HR-positive metastatic disease. The robust and accurate biomarker testing is the key to optimizing patient outcomes, as I showed you, and novel combination therapies are emerging as more efficient than treatment options. Yeah, maybe this is the last slide, but this is more comprehensive in the situations once again. Endocrine-sensitive metastatic situations or de novo metastatic AI and CDK4/6 inhibition treatment of maybe standard therapy. If it's AI-resistant but PI3 kinase negative, you have to measure it. It's fulvestrant and CDK4/6 inhibitor. If you measure it and you have a mutation, despite if it's tissue or liquid, you have to use inavolisib in the situation. Then it's come to the second line, and this is the king's discipline for me now. There are two decisions. First decision, switching to chemotherapy, or the second decision is this something for endocrine therapy? And then you have to take the decision in the future, if you go for endocrine therapy, is this a patient for monotherapy with an endocrine sensitive pathway, the Monday patients, or is it a patient in endocrine pathway with combination situations? I think with SERDs, PARPs, PI3 kinase, AKT, mTOR inhibition, as I showed you in this situation. And then it comes, if you say this is maybe the playground for the chemotherapy, you start mostly if you have had to low, ultra low with T-DXd or with ADCs afterwards, like sacituzumab or Dato-DXd. I think the future will tell us, maybe if it's implemented more and more, like the liquid biopsy testing during the first line and the treatment decision, tailored decision because of that one. I think the endocrine therapy will change probably this year, the backbone of CDK4/6, persevERA probably is coming. I think the next SERDs are knocking on the door in the first line situation. I think we get more and more newer ER backbones in the situations like CDK2, 4, CAT6, the trials are running in this situation. I think it's coming. I think we have to clarify if we switch to a chemotherapy, ADCs, yes, so I get more and more data, but maybe are there substantial benefit probably additionally from immune therapy? It's an open question, the trials are ongoing. What is the optimal sequencing of an ADC? This is an Oxford debate, no one knows it correctly in the situations. And how much target is needed and what I have to measure to have treatment decisions for ADCs, this is an open field. Many thanks.
The landscape of hormone receptor positive metastatic breast cancer is getting complex. So as we have more biomarker-driven drugs available, and the combination strategy based on biomarkers is important. That is the key message I learned from this the lecture. So any questions or comments from the floor? While the audience is thinking of the questions, so you have the patients who has a PIK3CA mutation, you start the PI3 targeting incorporation from the beginning, maybe to overcome the resistance, to prevent early recurrence. But as long as when they recur, despite the PI3 targeting agents, still tumor has PI3 mutation, you recommend incorporate PI3 targeting agent? So if the patients are treated with INAVO, then recurred, progressed on INAVO, then what will be your regimen to recommend?
So now it's switching to Sankain votes, 50-50. So,
50,
so maybe everything 100% have PI3 kinase. This is the most important factor, I'm thinking.
You mentioned about the PI3 ESR mutation, AKT mutation. If the patient has co-mutation, PI3 mutation, ESR mutation, combination strategy can be given. But if you select one drug is available, so which one do you recommend?
So first of all, I think we have data for both, and the data are comparable. If you're looking at deeply in the data, the co-mutation is nothing to say. We can't say PI3 kinase is over ESR1. I think we have no idea, and it's a data-free zone. What we are doing mostly is we're looking at the maybe clinical impact. If we have a patient probably 24 months, 36 months on CDK4/6 inhibition with PI3 kinase, probably PI3 kinase is not the driver of the resistance, because this is an intrinsic mutation starting maybe 10 years ago from the primary situations. But all the other patients coming earlier with relapses, maybe without any knowledge and data-free zone, I would say if I have a dual mutation or double mutations, I would say treating PI3 kinase-driven tailored decisions. So that's what I would do in my daily routine.
So when do you the diagnostic, when you examine diagnostic test from the beginning, or patients who has a high risk of recurrence in adjuvant setting, when they recur the first line, second line, the timing of the biomarkers say?
So maybe we have the chance and we test, like you wrote, nearly everything. So, but then if I get both the ESR1 mutation and PI3 kinase coming back, the patients ask me, why you give me fulvestrant in the INAVO combinations? Can you give me a ZERD? Because the people are reading more and more. I can't answer it, so, but I only can, maybe I wouldn't give a ZERD in the combination because we have no data for that. So that's why maybe we are testing, but maybe if we test and have no decisions on that testing, sometimes we have longer discussions.
Paul, last question.
I'll just end the afternoon on a really, really easy one for you, Shirku. So we are learning in BRCA1 and BRCA2 that there are pathogenic mutations that seem to have are stronger drivers of metastatic disease, and there's been revision of BRCA1 and BRCA2 and some of the frameshift mutations, et cetera, and so from a PI3 kinase and from an ESR1 mutation, do you feel that we may be able to create an order in terms of which ESR1 point mutations or truncations, frame shifts, and PI3 kinase? Because not all PI3 kinase mutations seem. So do you, when you get your reports, are you able to filter on the particular subtype, or does it tell you just that you've got a mutation in this gene?
So I'm not a molecular pathologist. First of all, is from the data, the different ESR1 mutations nearly have the different median PFS. So this is if you have an ESR1 mutation. If I was reading the New England Journal paper of the INAVO trial and compare it with the SOLAR-1 New England Journal paper, then I saw the difference of 14 maybe axons are different measurements. I have in the SOLAR-1 trial, I have a tissue archived tissue embedded. I missed axon 2, axon 4. I only have 7, 9, 20, and some amino acids. If I'm looking at the Foundation 1 liquid from the INAVO 120 trial, it's 13 or 15 different amino acids, exon 2, additionally exon 4, completely different tests in this situation. So my recommendation for that one as a clinician and not molecular pathologist, using the test where the phase 3 trial was doing in the situation. If you have the liquid and if you do it like the test amount of the Navo 120, I think this is good. And if you have a cell, I think more than 1% of in this ctDNA, I think is sufficient in this situation. This is what I know. But we have to train our molecular, or maybe you have to inform our molecular pathologists to say, looking at the newest publications and what they have to focus on measurement.
So the last question is, do you detect the increase the accuracy of the detection rate, PIX3 mutation, ESR mutation, do you do in tissue or liquid biopsy, or they are complementary? Do you agree with that?
First of all, I trained our pathologists to look at the different axons in tissue. So maybe we love to do it in tissue, and maybe if we're going for, maybe in Germany it is like the pathologists can do it in liquid both situations. If we have PI3 kinase negative in liquid, we repeat it in tissue. That is what we're doing in our pathway.
Initially, the polling question, the result is that most of the audiences just go to for oral votes, votes, but after the lecture, most of the audience, half and half, prefer the PIX3 mutation. So your lecture is important to guide the treatment sequence in metastatic breast cancer. Thank you for the wonderful lecture. So I'd like to close this session.